the June edition of the European Urology Podcast. My name is Declan Murphy, urologist here in Melbourne, joined as ever by my co-host on the European Urology Podcast, Dr Nikita Bhatt, who is up in Newcastle in the UK. Good morning or good evening to you, Nikita. How are you?
I'm very well. Thank you, Declan. How are you this morning?
It is morning. Yep. That's the problem with doing these podcasts from one end of the world to the other. It's 6 a.m. in wintry Melbourne, and it is, 9 p.m. in nice summery UK, kind of?
9:30. Yeah, summery / rainy, but yeah, we'll take it. We'll take the sun whenever we can get it. So.
Yeah, well, look, it's great to join us. We have another cracking edition of European Urology out this month in June. Gee, it was difficult going through the spreadsheet with you, trying to pick out, we normally pick out 2 highlight papers, and then we have Eoin coming into the studio to talk about a few other highlights, but it was difficult, wasn't it? You did very well trying to pick out top papers this month, Nikita.
Yeah, I mean, it was really tough. Obviously, I had to go for the good benign paper because, I have to do that with my little benign hat on. But I got a few good cancer papers in there as well. So hopefully have a nice mix for everybody to listen to.
Absolutely. But yes, oncology does make up a large part of urology, of course, but especially in the big journal, we often have these high impact factor papers, but everybody loves when we don't talk about things like prostate cancer. So yes, coming up this month, we've picked out 2 cracking papers. The first is an oncology paper. It's a very nice prospective randomized control trial on patients with high-risk non-muscle invasive bladder cancer from Denmark. And this is testing whether a urinary biomarker can be used to reduce the number of cystoscopies. So a very nice randomized trial. We'll be going to Aarhus in Denmark to talk to Thomas Dreyer. And then Nikita will be off to Cambridge to chat to Ollie Wiseman about the PURE randomized trial, the PURE RCT. I think it was EAU this year. It was read out. A randomized trial in stones, testing whether lithotripsy or flexi-ERS is better, I think, or something like that. But you'll be handling that discussion because I don't know much about stones. Nikita, thankfully, everyone will be really, really pleased to hear I'm not trying to talk about stones, including my old mate Ollie. And then finally, here in the studio today, we've got my fellow Eoin Dinneen sitting with us here. If you're watching on YouTube, Eoin is doing a fellowship with us here in Melbourne. He's actually an old friend of the podcast. He did this segment in the past before, and we'll be getting Eoin to see what else caught his eye in the journal this month by picking out a few other highlights. But first of all, let's go to Denmark, and I'll catch up with Thomas Dreyer to talk about the Xpert randomized trial of this urinary biomarker. So for our first paper on this June edition of the European Urology Podcast, we're going to Aarhus in Denmark to talk to Thomas Dreyer, who's the first author on this very nice randomized control trial of a urinary biomarker. Thomas, welcome to the European Urology Podcast.
Thank you very much. It's an honor to be asked to talk about my paper, or our paper, I should say.
Oh, well, the honor is all ours. Congratulations. It's a big deal getting a paper published in European Urology these days. We're all too used to the very high rejection rate, so it's always a great achievement. And it does take things like a prospective randomized trial nowadays to get in. So congratulations on this, which is the Xpert Bladder Cancer Monitor Urinary Biomarker Test. I think the acronym is XBCM. Xpert. Xpert is, I think, a commercial name, Bladder Cancer Monitor Test. And so a very nice randomized control trial for high-grade non-muscle invasive bladder cancer. We're going to ask you to briefly summarize the trial and the data. But of course, in this short segment, we're not going to go through the full thing. We'll put a link in the show notes, and we encourage people to go and have a look at the full paper themselves, of course. But we're interested in getting the high-level summary and have a quick chat about it. But from my take on it, the background is this is an intervention to see can we improve the way in which we monitor patients after their diagnosis of high-grade non-muscle invasive bladder cancer, because of course traditionally that's involving cystoscopies and lots of cystoscopies, and that's the reason why non-muscle invasive bladder cancer is one of the most expensive cancers in the world, because it does require a lot of monitoring using cystoscopy. And I understand this trial is to determine whether the Xpert Bladder Cancer Monitor biomarker could be used alternately. So instead of having a cystoscopy every single time, could we use this urinary biomarker test alternately as a way of reducing the number of cystoscopies and so on? But over to you. Tell us a little bit about the trial.
Yeah, first of all, thank you for the introduction. That was very nice of you to say. We are also very happy about the publication. To go into the trial, it is, as you say, a randomized controlled trial which only took place in Denmark. We randomized approximately 400 patients between follow-up with either cystoscopy or intervention arm, where we alternated between cystoscopy and Xpert bladder cancer monitor urinary test. So it's important to say that we are not completely stopping using the cystoscopy. We use it alternatively with a urinary biomarker test. The study was conducted because a lot of studies regarding urinary biomarker tests have shown that they have high sensitivity, specificity, and in general very good diagnostic performance. But there has been a lack of trials actually looking into the clinical side of or clinical consequences, I should say, of using the urinary biomarker test. So we took the step and did a randomized trial where we actually replaced cystoscopies with the urinary biomarker test, and I believe we are one of the first to do so. And specifically, we went for high-grade disease because the follow-up schedules for high-grade disease is, when you look at the guidelines, are more intense, and thus there are more cystoscopies to be replaced, actually. We chose this test because, as many of the other urinary biomarker tests, it had been shown high diagnostic performance. What we found in the test is that we found an equally many recurrences of high-grade non-muscle invasive bladder cancer or metastatic disease or muscle invasive bladder cancer in the intervention arm, where we alternated between cystoscopy and urinary biomarker test. But of course, some might speculate, how many cystoscopies did you actually end up doing? But we actually more than halved the number of cystoscopies performed in the intervention arm. So it was a significant reduction in cystoscopies, and thus, even though we found equally many recurrences or progressions, there was a fewer cystoscopies, and thus we saved the patients an unnecessary investigation, which could lead to urinary tract infection, higher costs, etc.
Yeah, well, so that was the primary endpoint. That was the whole point, wasn't it? To see can you reduce the number of cystoscopies, but still have the detection rate pretty much the same. A couple of questions about that. So first of all, the recurrence rate in both arms was actually much lower than you anticipated. You did pick, as you say, high-grade non-muscle invasive, and they'd all had one check cystoscopy following their diagnosis. So you'd kind of taken out some of the poor performers and left behind those patients who, still tend to have quite a lot of recurrences. But I think the statistical analysis had estimated 50% recurrence, but at the end of the day, there was only 11 or 12% in each arm. Any thoughts on why that might be?
We already touched upon that we only included patients after the first cystoscopy, which we know is if they don't have a recurrence at the first cystoscopy after TURB, they have a lower recurrence rate. And we only included after we knew that they didn't have this recurrence at the first cystoscopy. So that's one reason why we might have seen a lower than anticipated recurrence rate. Furthermore, the 50% recurrence rate is based on mainly historical data where newer installation therapy might not have been as widespread as it is today. Furthermore, we didn't include only patients right after their first tumor. We also included patients up to 2 years after they had their first tumor. So there's some heterogeneity in our population that might explain this lower than anticipated recurrence rate. And of course, we have to, when we interpret the results, think about the power of the results and the statistical power.
Yeah, but nonetheless, it's very reassuring to see how it holds up, even with the lower occurrence rates. We're still seeing non-inferiority, which I think was the end point of the trial. Another question, Thomas, is you write very nicely in the paper about the anticipatory effect that you see in this trial, and also in other urinary biomarker trials. I think by that you mean the fact that some of the biomarker can become positive before we might see something on a cystoscopy. Can you explain that a little bit more? What do you mean by the anticipatory effect?
Yeah, with the anticipatory effect, I mean that we have a positive urinary biomarker before we're able to detect a recurrence visibly. Our gold standard at the moment is cystoscopy, so we can treat or we usually don't treat unless we see something, unless it's preventive with, for example, installation therapies. Of course, we have chemoablation installations, but that's another case. So we're able to sort of predict sometimes the recurrence using the urinary biomarker. And what we saw that we often saw a positive lead time with the urinary biomarker being positive before a visible recurrence of up to half a year, or even a year before we saw the positive biomarker. Of course, you have to account for false positives and how do you when is a test false positive and when is an anticipatory positive, and that's difficult to answer. But the fact is that more than 50% of the patients who ended up having a recurrence in the intervention arm were positive before we actually were able to detect it on the cystoscopy. So more than 50% had a positive urinary biomarker at least 4 months before we were able to detect it with cystoscopy. So I think that's evidence that the anticipatory effect is there. Of course, we can't completely neglect false positives, but I think it can be utilized to maybe select patients who are at a high risk of recurrence. And that's actually what we have done in our local institution at the moment. Put these patients with a urinary biomarker test that is positive on a separate track in follow-up compared to those who are negative.
Excellent. Now, what about the health economics of it? Because it's good already that you're reducing the interventions for the patients. That's a good thing. More than 50% of cystoscopies are avoided or reduced. Does that save money? I know it'll vary from health system to health system, but in Denmark, for example, would this save money? How do the costs of the biomarker compare with a cystoscopy?
I can say with the local agreement that we have, that the test per test compared to per cystoscopy, we are saving money, and we expect to save quite some money that will be free to other causes. So I can't disclose the exact price, but I can say that it's cheaper per cystoscopy, both when you look at the reimbursement and also micro costing. So cheaper, but I can't say exactly by how much at the moment.
Yeah, one of the problems, this is a good socialized country like Denmark, like many EU countries, but in some countries where urologists get paid to do cystoscopies and it's mostly private practice and, in fee-for-service environments in the US, for example, urologists might be aghast at the idea that they will be doing less cystoscopies. I'll just throw that one out there. I don't expect you to fully answer it, but we have similar problems with hypofractionation for radiotherapy, for example. If you get paid by fraction, then the provider or the business who owns the machine has sometimes less of an incentive. But nonetheless, you'd like to think that the right thing, of course, is to be doing less interventions. And if it saves money overall across the health system, as you've just described to me, that's a good thing. Now, my last question. Sorry, go ahead.
Yeah, no, I was just about to say that it's difficult for me because I don't fully understand how it works in other countries enough to say exactly how it would work there. But it's true we have this generalized healthcare system where we have to think about cost effectiveness globally in the whole country, not just a local practice.
That's a good thing. Now, finally, so where to next for this? This is a very nice trial published in a big journal. Are we expecting to see this get a mention in a guideline, or are there bigger trials necessary? What's going to happen next with this XPCM?
For me, I would say it should be mentioned in the guidelines, is my opinion. Of course, I'm biased. What I can say is that in the Danish guidelines, we have a separate guidelines which are not exactly like the EU. We have our own the national guidelines. It has already been implemented. Okay. So in the Danish guidelines, we have can do for high-grade follow-up of high-grade non-muscle-invasive bladder cancer. We recommend either cystoscopy as we know it, cystoscopy-based follow-up, or you could do it with the Xpert bladder cancer monitor in a schedule that you determine based on the trial.
Well, how satisfying.
Yeah, it's really satisfying, and we have already implemented it in Aarhus and our satellite clinics from Aarhus. So we're actually doing it at the moment, and of course we will be monitoring how it goes with the real world data.
It is so satisfying. Local colleagues in Denmark conduct a multi-center prospective randomized trial. It gets into guidelines. It reduces cystoscopies for your patients. So congratulations, Thomas Dreyer, and to your team in Denmark for this very nice work. And we look forward to seeing more from this. Congratulations.
Thank you very much. And thank you for having me.
So, Declan, that was a really interesting paper, something very novel. Do you really think that biomarkers can replace cystoscopy for bladder cancer?
That's the question to ask, isn't it? After a nice randomized trial like that, and congratulations to Thomas again and team. He's a trainee, by the way, in Aarhus, so big achievement for him.
Wow.
Yeah, it's great, isn't it?
Very impressive.
Great young communicator. But that's the question, isn't it? And look, it's great. Non-inferiority trial shows you can more than half the number of cystoscopies for these, not just non-muscle invasive, but high-grade non-muscle invasive cancers. So I think it's a question that has to be asked. But you might say, well, why hasn't this happened before? There are other urinary biomarkers around. They haven't quite broken through in this domain. But as he optimistically said at the end there, he is optimistic it'll be in big guidelines like EAU, and they're already doing it in their own clinical practice in Denmark. So which I think is fantastic. And it's one thing doing an academic trial, etc., but to actually change practice is very rewarding for them. It was really nice to hear that, wasn't it?
Yeah, absolutely. And I think there's a lot of promise for this, especially in the NHS, because cystoscopy lists, we're always finding people to do them. And, if we can, especially for the elderly population, replace at least a few of these cystoscopies with biomarkers and such, I think it would make a big difference. So, yeah, really looking forward to seeing this in the guidelines so that we can implement it in practice if that's something the UK would take up.
Yeah. So listeners and viewers out there, please, watch out for this. And if you get the opportunity to be having a trial in your own department, you should do that. Reduce those numbers of cystoscopies and so on. Great. Well, look, let's go on to our second paper now. For you, Nikita, you're going to your old buddy and my old buddy as well, Oliver Wiseman in Cambridge, who's the first author on this pure randomized control trial. So let's hear what you and Ollie had to tell us about this trial.
Okay. So, coming on to our second paper for today, I am delighted to introduce Oliver Wiseman, who needs no introduction. He's really well known, and I have had the pleasure of working with him while I was in Cambridge. He's an endourologist based in Cambridge University Hospital, but I'll let him introduce himself further because I'm sure he has a lot of accolades to add to that. And then we're going to discuss his paper, which is a pure RCT that I'm sure everybody has heard of before and probably seen being presented at EAU this year. I'm very proud to say that's the UK-based randomized control trial. So we're going to discuss that next. Hi, Ollie. How are you?
Hi, Nikita. Yeah, thanks very much for asking me to be on. It's a pleasure to be here and to talk about the Pure 1 RCT. As you say, I'm a urologist in Cambridge, an endourologist, part of a big team that was involved in the 2 Pure RCTs, part of the chart team from Aberdeen, who have a long pedigree in producing stone-related studies from the UK. And maybe we'll mention a bit about that. It's really a pleasure to be here. Pure it's been a 10-year project really. So it's great that it's going to be published in European Urology. The RCT1 has been published in European Urology. RCT2 is going to be published in European Urology Focus. So we're going to talk, I think, mostly about RCT1 if that's the plan.
Yeah, absolutely. So I'd let you introduce sort of the paper yourself. If you can give us an intro about what it's about, the headlines, if you may, so that the readers can go back and look at it later in our journal this month.
Yeah, perfect. So the Pure study was looking at patients who have lower pole stones, and Pure 1 was lower pole stones which were between 1 and 10 millimeters in single dimension. And those patients were randomized across a number of UK centres, approximately 50, into having either shockwave lithotripsy or flexible ureteroscopy. And there were about 230 patients who were randomized into each group. And the primary outcome measures were the quality of life of patients, so measuring the area under the curve, looking at quality of life using the EQ5D up to 12 weeks post-randomization, and then also doing an economic analysis, so measuring the quality adjusted life years for up to a year actually after randomization. And so what the study showed was that if you look at the mean health status, so the areas under the curve over 12 weeks, there was a small insignificant difference in favor of flexible ureteroscopy over lithotripsy for these smaller lower pole stones. Complete stone clearance was higher in the first group, so it was 72%, and lithotripsy was only 36%, so a significant difference in stone clearance rates. The incremental cost effectiveness ratio, which is a calculation which takes into account the difference in quality of life and the value of a quality adjusted life year, was about £65,000, and the quality adjusted life year threshold is about 20k. So that means that lithotripsy is much more cost effective than flexible ureteroscopy. So very little difference in quality of life. Lithotripsy much more cost effective, and from the point of view of stone clearance rates and also need for repeat procedures, FIRS beats lithotripsy significantly.
Amazing. So obviously, as surgeons, we tried to look at the kind of more sort of surgical outcomes like stone clearance rate, or repeat imaging or repeat surgical intervention. And it's really interesting to see that an RCT of this level has used PROMs as the primary outcome. And trying to design an RCT around this, I know how difficult it is, especially kind of with stones, because as far as I understand, there isn't a stone specific sort of PROMs that exists or that is suitable enough to be used for an RCT so far. So what are your kind of thoughts around using PROMs, first of all, as a primary outcome in a randomized control trial? And what do you think about using a stone-specific PROM in the future? Do you think we're close to that, or are we far away?
Yeah, so I mean, great questions. I think that PROMs are crucial. We can judge our own results based on looking at scanning or based on a discussion with a patient of, should we do more surgery? But what actually really matters to patients is how it affects their quality of life, their worry about future stone episodes, ongoing effect of pain, the effects perioperatively, let's say, of a stent or of a nephrostomy tube, the need for a second look, let's say lithotripsy, or second treatment of lithotripsy, or a second look flexible ureteroscopy. So we've been pretty bad, I say, as a surgical community about thinking about things from a patient point of view. So I think it's really important that we do that. Now, I said that the study was kind of 10 years in the making, and we started recruitment in 2016 for the study, and we've been talking about the study probably for around 2 to 3 years before that, looking for funding. There was an HT application. It was funded by the NIHR in the end, for which we're very grateful. And so if you think about the evolution of stone PROMs, they really only started in 2017, 2018. So when we started recruiting in 2016, there weren't really any good stone PROMs that we could use. And so that's why we used a general quality of life measure, which was the EQ5D. Since then, the WISQUAL has been published and is increasingly used. That's from Steve Nakada's group in Wisconsin, and the first papers from that were 2017, 2018. When we designed the study, it wasn't available. And then since then, there have been other stone PROMs as well. There is the USIQUAL from Hrishi Joshi in Cardiff, and then we developed a Cambridge renal stone PROM more recently as well. And so, in fact, part of the study, we did use a stone-specific PROM. So we did use the CRESP, the Cambridge renal stone PROM. but we haven't analysed that data yet. So
Okay.
I think quality of life and PROMs are key. And I think even better if we can use a stone-specific PROM, that would give us even better results.
Yeah, amazing. So, I mean, sort of a follow-up question to that. So, stone-free rate obviously higher with the FIRS, but the PROMs difference wasn't that significant. So, I mean, do you have an explanation for that, or do you think if there's some residual stones, the patients are not bothered or doesn't, cause any symptoms, or how is there an explanation at all?
So I think that there are lots of patients who, have had lower pulse stones which may not be symptomatic. There may be small fragments which are left at the end of either 1 or 2 sessions of lithotripsy or 2 sessions of flexible ureteroscopy. And so they're not necessarily going to cause any symptoms for the patient and or affect quality of life. And in fact, if you look at the quality of life curves in the paper, they only go out to 3 months. But they are very, very stable. They don't budge after about 3 or 4 weeks, post-treatment. And so, we could have followed it out much longer, but that obviously involves, a lot more cost, a lot more patient involvement. And I'm not sure that it would necessarily show much of a difference. It might be that if you follow them out to, 3-5 years, that some of those small residual fragments would start to cause symptoms and affect quality of life, but that's not what we looked at in this study, and it might also be that further imaging will show that those small fragments go in time.
Yeah, absolutely. Sort of a technical question about, you've said the study kind of ranges over almost a decade. Have you seen a temporal difference in how FIRS outcomes have changed with improving technology and with lasers, improving, etc.?
Yeah, it's a good question. I mean, it's not something that we've looked at. It might be interesting to go back to the study and look at the first 100 in each group and the second 100 in each group. The scope technology that's been available, has improved over time, and that's mostly been getting smaller scopes, which will mean you'll be able to access the kidney first time, I think. I'm not sure that's going to necessarily affect outcomes so much. There may be a temporal blip if you need to stent the patient because you can't get access, first time. The lasers, I'm not so sure that we could say that the improvement in laser technology, so the higher powered lasers, and all the various pulse modulations will lead to a significant improvement in stone-free rates. I think that probably the biggest thing that's happened that I don't think has impacted our study, but may impact the success rates of FIRS going forward, is what's happened in the last 2 or 3 years, which has been the significant introduction of suction access sheaths. And I think the introduction of suction access sheaths is likely to lead to a better outcome for FIRS from the point of view of stone-free rates. Whether that translates, of course, into improvement in quality of life, I don't think we could say that from this study. But what it may well do is increase the cost further. So mean that actually, from an economic point of view, it's worse for Flexi. It's all speculation. It wasn't part of the study. But that's always one of the things that happens with long trials, right? Is that, by the time you come to the end of the study, some of the technology that you're using or some of the evidence that you had at the start has changed. And therefore, you don't necessarily have the exact same situation going forwards as you had at the start when you designed the study.
Okay. Yeah, absolutely. And then sort of commenting on benign RCTs and, the chart group that are, prolific in this area and have published so well and, led and supported a lot of trials in this area. I think tissue was there, they supported tissue as well. So similar kind of looking between sort of FIRS versus ESWL, but obviously for ureteric stones. So what what are your comments on how difficult it is to sort of do benign RCTs and the role of chart or trials unit like that in this field?
Yeah, I mean, Sam McClinton and the Aberdeen group have been absolutely fantastic, as you say. So the first study that they actually set up was Suspend, which looked at alpha blockers for ureteric stones. And then, as you say, it was then Tissue, which looked at uretroscopy versus lithotripsy for ureteric stones. And now we've got the whole Pure study, Pure 1 and Pure 2. So, it's a incredibly impressive portfolio for a benign disease that traditionally hasn't been very well funded. So we really need to thank CHART. We need to thank all the UK centres, my fellow co-author who was, Darren Smith as co-first author, and then all the other authors of the study, as well as the NIHR who funded the study. Benign studies like this really need to be funded. And the economic cost of stone disease is more than the cost of prostate cancer, bladder cancer combined. So, it's a very, very important area. And I'm hoping that funding will continue for these sorts of studies. And I really think that the next big study needs to be looking at how we can prevent recurrent stone formation. So, whether we need to do full metabolic workups on patients or whether we need to use empirical treatment of some sort to try and prevent these patients who come back with recurrent stones at significant cost and effect on quality of life, that I think would be, a great study to do. And I'm really hoping that, funders will continue to support stone research.
Brilliant. Thank you so much for coming and sort of sharing your paper with us today. And I'm sure everybody will enjoy reading it as much as I did. So thanks, Ollie.
Yeah, thanks a lot, Nikita. Thanks for having me. Nice to see you.
Nice to see you too.
Well, it was great to hear from Ollie Wiseman talking about that randomized trial. So what's your take on it? Lithotripsy versus Flexi-URS, Nikita?
I mean, listen to the masses, right? The patients say there's no difference in quality of life. So, and lithotripsy is cheaper. So I think as far as the NHS is concerned, it's a win-win for us. Go for lithotripsy first, and then I guess for us to follow for better stone clearance.
But it's kind of like what we were discussing with Thomas. Urologists like doing these procedures. Stone surgeons love doing Flexi-URS, don't you?
Yeah, I mean, I'm sure they do. But I guess with the current sort of, scenario in the NHS with lists and, waiting lists everywhere growing, I think it's, prudent that we listen to the patients and I guess do more lithotripsy if that's what they don't think there's a difference. So I guess, we have to listen to them.
Too right. Just because we like doing an intervention or it works well in your system doesn't mean that's the whole point about randomized trials, isn't it? And especially these patient perspectives, so important, as you said. So yeah, congrats to Ollie and all the team for that very nice randomized trial. So yes, I'm joined here in the studio by my fellow Eoin Dinneen. Eoin, good morning to you.
Morning, Declan. Morning, Nikita.
So Eoin has been on the podcast before. He joined us, I remember last year when we were recording on site, I think at the EAU, and you did this nice segment that Nikita used to do where we say, what else caught your eye in the journal? And a few little tidbits for the audience. But you're here in studio because you're doing a fellowship here in Melbourne at the moment, aren't you?
Sorry. Yep. Been roped in.
This is part of the
Invited
job.
in.
You have to. What time did you get up this morning?
Got up at 5 o'clock this morning.
5 o'clock. Now here in Australia, we don't get up early. It's not like it's the US where they do a ward round at 5 a.m. before the boss comes in. So, but if you're doing a fellowship at Peter Mac and you've got the European Urology slot this morning, you have to get up at 5 o'clock and come over here to my house. So
I'll warn my successors.
And then what are you doing immediately after this once you get out of the studio?
There's a Renu who normally sits in this chair for GU cast is doing a prostate this morning. So I'll be skedaddling across town to go help her.
Get some console time.
Not me this morning, Krista.
Oh, Krista Bhatt, our other fellow. Very good. Yeah, look, great. So, well, thanks for having a look at the rest of the journal. As myself and Nikita said at the start, there's a lot of good stuff. So you're only allowed 3 and you're only allowed a minute or so for each. So tell us what else caught your eye. And of course, we will be putting the links in the show notes. So if Eoin convinces you that this is worth a look, you'll be able to find the full details in the show notes.
Lovely. I'll try my best in 3 minutes. So I've got an editorial, an RCT, and a surgery in motion. First with the editorial, something a little bit different. It's only short, 600, 700 words. This is written by Brant Inman and Andrew Vickers, and it's the importance of precise scientific communication. Non-randomized trials should not be described as phase 3, and registrational intent trials should not be described as phase 2. A little bit of background on why we call trials by phases, pointing out that phase 1 trials are for first in human and concerned with dose finding. Typically in oncology studies. Phase 2 trials for oncology will address the kind of go, no go question. Does it look like there's merit in this, there's mileage in this? And then phase 3 are typically randomized control trials with a new agent or combination against standard of care, looking at really important outcomes such as progression or cancer specific or overall survivals. They point out that actually there's been a good number of trials mislabeled according to this original description from the FDA in 1962. Some of them published in really high impact urology and medical studies, but they come back to point out that, precise terminology is going to be helpful, and sticking to it is in all of our best interests. So as I say, it's pretty short. It's a little bit of a refresher and an intro onto how we got to call what we describe and what we publish.
So I suppose the point being, we're supposed to know, aren't we, Nikita, what's a phase 1, phase 2, phase 3? But I think the reason Brant and Andrew have written this is because we're getting it wrong some of the time, I suppose. So it's a useful little tidbit, you think?
Yeah, for sure. Yeah, absolutely. I really enjoy reading it. I think it's very informative, and I would greatly recommend it to anyone.
There you go. Thank you. Number 2.
Yep. This is the original article, randomized control trial. First author is Johan de Bono from London, and senior author is Christopher Sweeney. This is the final overall survival and molecular data associated with clinical outcomes in the ipatasertib and abiraterone phase 3 ipatential 150 trial, international large randomized control trial in the castrate-resistant metastatic prostate cancer setting, where median survival is under 3 years, so an important space. 1,101 patients, 547 of whom were randomized to ipatasertib and abiraterone, and 554 to placebo and abiraterone. Abiraterone was dosed at 1 gram a day, and prednisolone with that 5 milligrams twice every day. So you may remember that the ipatential 150 trial was originally published in The Lancet in 2021, the primary outcome of which was radiographic progression-free survival in the intervention arm. And this was a positive study with a hazard ratio of 0.77. Confidence interval was just snuck under the 1. It's 4 years on now, and it's interesting to note that there was no difference in overall survival, neither in the full analysis set on an intention to treat analysis nor a pre-specified P10 loss subgroup. Sorry, I should go back and say that ipatasertib is an AKT protein kinase inhibitor. So the comment on this is that, again, it highlights the heterogeneity of castrate-resistant metastatic prostate cancer, and inhibiting the AKT pathway did not seem to make a difference here. And I think it's a caution against using surrogate markers, early surrogate markers, for potentially more meaningful oncological outcomes in the later setting. I would also say that it was helpful having read the comment piece by Andrew Vickers and Brant Inman about phase 1, 2, and 3, because they do go into the details, some of the details of their phase 2 planning and dose selection and things like that. So they were complementary articles, actually.
And it's the point about in oncology, you do have to wait for OS usually, and this is just a good cautionary thing about that, because in the US things will sometimes get FDA approved based on RPFS, which was what was originally reported in the IPAT 150, but then you follow them a bit longer and there's no difference. So you're balancing up toxicity, cost, etc. And guess what? They don't live any longer or live any better. The two key things for us: overall survival or quality of life. So I think it's a really useful thing, and congrats to the team to be involved. But you have to wait for OS, I think, for very many of these before you sort of really think about changing practice. So I don't know, Nikita, your thoughts?
Yeah, I mean, I don't deal a lot with prostate cancer, but that's something that I'll take away for my next MDT. I guess don't wait for the OS for your next trial.
Exactly, and that's important for all of us to understand, and that's why that's kind of no longer a thing. Anyway, doing AKT inhibitor at the moment, at least with that combination, and and it's also important to publish these in journals. Full stop. Everyone wants the positive endpoint, the big readout, and you get published in a really big journal. But when we have these well-conducted phase 3 trials, it's also important to report the negative ones. And sometimes it doesn't happen, sometimes these just disappear, or they get an abstract turns up at a meeting. But this is an important thing to have in the journal this month.
Yep. I think there's probably more from this team on this very trial as well. There's a long list of markers and biomarkers that they've been exploring to see whether there's any subgroup analysis that benefit. So I'd say that watch this space from that
and finally
eminent team as well. And finally, something closer to my heart again, this is the Surgery in Motion. This is a first-in-human study of dual modality PSMA targeted probe for preoperative PET CT and intraoperative fluorescence imaging in prostate cancer. This is first author is Silu Chen. This is a team from Peking University First Hospital. This is a preliminary study of 16 patients who had gallium PSMA radioligand administered the day before surgery, had 3 PET scans later on, PET CT scans later that day, one at half an hour, one at an hour, and one at 2 hours after administration of the radioligand. And the next day at 24 hours later, plus or minus 6, they had their robot-assisted radical prostatectomy. They go through some of the PET CT images and look at uptake and SUV and so on. But the bit that really caught my eye was the Firefly mode on the robot console to look at areas of PSMA labeled near infrared fluorescence. They report no adverse events in these 16 patients. And the exciting bit for me was that in 2 patients, they saw fluorescence on the Firefly mode in the prostatic fossa surrounding the prostate once the prostate was removed from the pelvis. And secondary resection was performed in both of these patients. And the final histology showed prostate adenocarcinoma there. When they looked for the probe on fluorescence mode at the actual prostate for surgical margin assessment, the sensitivity was 100%, specificity was 43.8, and so that's interesting because there were some false positives. And when they looked closer into those, they saw that although there was not prostate cancer at the margin, there was prostate cancer very nearby. That kind of makes sense that you're seeing that fluorescence from the very nearby prostate cancer. Yes, so that would be the highlights for me. My comment here is that this looks attractive. If you can do 2 things with one radioligand, that always seems to be a pretty good use of time. Although the idea of having 3 PET scans the day before your prostatectomy is clearly not going to be a runner in many healthcare systems. The best thing here is that the idea of spotting residual disease within the patient rather than trying to understand where the margin is positive and then correlate that with where you think the residual disease may be. But clearly there's a limitation here in that the false positives, because in many cases where the MRI and where your preoperative predictors make nerve spare or going tight to the prostate a difficult decision, there will be prostate cancer very, very nearby, and false positives will muddy the water. But perhaps I wouldn't be surprised if we see this move forward, and maybe the thing is not to look at the prostate, but to look at the tissue surrounding the prostate. But very interesting work.
And it probably caught your eye because of your own interest in intraoperative margin assessment with the NeuroSafe trial that you were first author on recently. And I think this is one of the hot topics in 2025, Nikita, intraoperative margin assessment for people doing certainly prostate cancer surgery, but it may well be for kidney cancer surgery as well. Other surgeries is using technologies like this, not just frozen section as you did in NeuroSafe, but here we have fluorescence guided imaging based on PSMA, histologous confocal microscopy, Raman spectroscopy. So it's an exciting era. I think because of NeuroSafe, there's now a lot of interest in other ways of intraoperative assessment of positive margins or node positivity, etc. And this is a nice bit of work from our friends in Beijing.
Yeah, it's really interesting. And I mean, if you can translate that into nodes as well for prostate and bladder, I think it would really help. So yeah, great articles highlighted there on.
And a nice video going with it, I presume. I haven't seen it yet, but yeah, it's surgery in motion. So it's our
beautiful figures in the paper as well. Yeah. Absolutely colourful, tabulated and correlating intraoperative pictures with final pathology and the preoperative scans as well. It's very nice.
He's picked a good spectrum, hasn't he?
Yeah, for sure.
He's had phase 3 oncology trials. He's had a nice gadgetry image looking robot thingy. So we love all those 3 things.
Survive another month at the Peter Mac.
Always love the robot.
Great. Well, look, that's it, I think, Nikita. It's been another cracking version of the European Urology Journal, and hopefully an enjoyable podcast for people as well.
Yeah, absolutely. And hopefully everybody enjoys the kind of spectrum of articles we've picked up, but there's a lot more within the journal. So go and have a read of this month's issue.
Yeah, and we'll put a link to the full index as well in the notes. Thanks very much to everyone at European Urology for supporting the podcast, and for the authors, and for Eoin for coming on to talk this month. Thanks to the team at GUcast who produce the European Urology podcast. And yeah, we'll be coming back soon, Nikita, with the next edition of the European Urology podcast next month.
Yeah, absolutely. So please do subscribe, rate, and review us wherever you get your podcasts. And like Declan said, please do join us next month. And if you have any feedback or would like to listen to something on the podcast, let us know. See you next month.
Thank you.